discuss lung mechanics part 1. Lung mechanics must be to know about pressure and volume and flow and the relationship between each other, and passive dynamics like compliance, resistance, and time constant, and lasting equation of motion. Spontaneous breathing is different from positive ventilation. Spontaneous breathing, this means negative interpleural pressure. Alveolar pressure becomes subatmospheric pressure. Gas flow down pressure gradient into the expanding lung is entirely passive via elastic recoil. Positive pressure ventilation. Ventilator applies positive pressure at the proximal airways. In this time, alveolar airway pressure more than alveolar pressure. Air pushes into the resistive airway, expanding passive alveoli, increasing intrathoracic pressure throughout the inspiration. Expiration occurs when the valve opens to the lower baseline PEEP. In the positive ventilation, there is inspiratory phase, the valve open and flow the air until the lung alveoli. After the expiratory phase starts when the inspiratory valve close and expiratory open. In this time, the patient exhale all the air, just residual pressure as a PEEP. There is three fundamental physical parameters. There is pressure and flow and volume. Pressure is the force required to overcome the airway resistance. Flow, speed of the air, this displacement over the time filling the pulmonary airways. The volume, amount of air, the cumulative quantity of the gas delivered into the lung parenchyma during the inspiration, expressed in milliliter or liter. There is 6 pressure you must be know. You must be know about peak pressure, the maximum total pressure. Plateau pressure is the static alveolar pressure at the end of inspiration after inspiratory hole or zero flow. PEEP, positive end expiratory pressure, the remaining of the end exhalation. Driving pressure, the difference between plateau pressure and PEEP. Transpulmonary pressure, the difference between the alveolar pressure and pleural pressure. Mean airway pressure, average pressure over the interior respiratory cycle area under the curve. What's important between the peak and versus plateau pressure? Peak pressure, it means the pressure you need to overcome the resistive airways. Plateau pressure is responsible pressure to the stand of the alveoli. This measured during end expiratory occlusion, zero flow. What important? Peak or plateau pressure? They find in the ARMA study, as ARMA trial during COVID and ARDS cases, they found the plateau pressure must be less than or equal 30 centimeter water. In this time, you prevent any paratrauma or voluotrauma. Transpulmonary pressure concept. Transpulmonary pressure alveolar minus pleural pressure. From the ordinary patient or regular person, the pleural pressure must be 0. This means your plateau pressure is accurate. If you measure it, it's 30 minus 0, it equals 30. This is your accurate plateau pressure. You have lean patient, peak pressure 25, plateau pressure 17, pleural pressure 0. This time, transpulmonary pressure equals 17, equal plateau pressure. In obese patient, high abdominal pressure, peak pressure 45, plateau pressure 31, and pleural pressure positive 20. It's mean 31 minus positive 20, in this time 11. This means the patient not have adequate plateau pressure. You can increase your plateau pressure more than 31. Patient self-induced lung injury. And this time the patient came to your ER and the patient have rapid respiratory breathing, excessive respiratory breathing. Strong patient inspiratory drive generates deep negative pleural pressure, -5. In this time, if plateau pressure 20 minus 15 equals 35. The patient high plateau pressure, and this time equalization of the air inside the alveoli and atmospheric pressure, and the patient suddenly become arrested and fatigued and intubated in this time. Driving pressure, delta pressure in the ARDS survival. Driving pressure in some trials they notify us in some patient. If the patient have driving pressure more than 15, this is the difference between plateau pressure and the peak pressure. This patient have high mortality, so that they found this patient high survival if the driving pressure less than 15. Mean airway pressure and oxygenation. Determined mean airway pressure represents the average pressure exerted on the lungs across the total respiratory cycle time, area under the curve. Intervention to increase. You can increase the mean airway pressure by increasing the PEEP, extend inspiratory time, IA ratio, and increase the peak and the plateau pressure. Direct impact in oxygenation, higher recruitment, collapsed alveoli, and increased mean surface area for arterial oxygen diffusion. Airway resistant dynamics. Sometimes the patient have resistant equal peak minus plateau on flow. Normal less than 10 centimeter water per liter per second. This the least pressure you can give the patient intubated baseline resistance. This increase when the patient bronchospasm, asthma, and COPD, secretion accumulation, mucus plug, kinked or narrow intracheal tube. Reflection in your mechanical ventilation, the curve increase in the widening the gap in between the peak and the plateau pressure. Static lung compliance dynamics. Static compliance formula equal tidal volume over plateau and minus PEEP. This causes low compliance. Normal compliance must be from 40 to 50. Low compliance ARDS, pulmonary edema, lung fibrosis, consolidation, pneumothorax, pleural effusion. Both peak and plateau pressure high in mechanical ventilation. Equation of motion is the total pressure. Total pressure equal flow multiply resistance, this means overcome the airways, volume over compliance, this distension of alveoli, plus beep. Resistive component, pressure required to move the gas through the conductive airways. Elastic components, pressure required to inflate the elastic alveolar chest wall. Baseline pressure, baseline for exhalation. This residual of post-exhalation, peak positive end expiratory pressure. Time constant. What mean by time constant? C2 time constant, inspiratory, expiratory. In inspiratory time constant, the time you need to deliver the air to the alveoli, you have 3 time constant, and the time you need to exhale all the air from the alveoli, 3 time constant, as a half-life of the drugs. So that is important for us, 3 exhale time constant. In the normal patient, 0.5 to 0.7 second exhalation time constant. For exhalation required to remove all the airs from the alveoli, you need 3 times time constant. So that 1.5 to 2.1 second to remove all the air from the alveoli. It's different according to the case. If the COPD case and asthma, high resistant, prolonged time, require long time constant. ARDS, low compliance, short time constant, you need maybe in COPD like 2.5 and ARDS 0.9. Auto beep or dynamic hyperinflation mechanism of air trapping. A negative inspiratory to prevent for exhalation before next breath, and expiratory alveolar pressure become positive, increase work of breathing. Clinical manage auto beep, increase expiratory time, increasing the peak flow and reducing respiratory rate, reduce tidal volume and mid ventilation, treat the underlying airway obstruction and bronchodilate. Summary: core variable interconnected. The pressure overcome resistance and compliance to deliver the flow and the volume into the respiratory system. The differential between the peak and the plateau. In isolated peak elevation indicate airway resistant issues. Concurrent pulse, peak, and the plateau elevate indicate lung compliance failure. Protect the alveoli. Keep and driving pressure to minimize ventilator-induced lung injury and improve ARDS survival. Must be plateau equal or less than 30. Driving pressure less or equal 15. Respect the time constant. Must be 3 times time constant to prevent air trapping, auto beep, dynamic hyperinflation.